Hello and welcome to another episode of Celebrating Southbridge. I'm Ron San Angelo, Southbridge Town Manager, and I have a great guest on today. The person that I have on today is Ed Moore, the Chief Executive Officer and President of Harrington Hospital. Ed, welcome to the show.
Thank you, Ron. Appreciate it very much.
You know, Ed, it's really great to have you because as far as I'm concerned, the hospital is one of the best assets that the town of Southbridge has. It really is a tremendous part of our community. So I wanted to talk to you about some of the things going on at the hospital. I know you have a lot to brag about today. A lot of good things are happening there. But first I want to thank you. I want to thank you because I've seen firsthand how much your hospital has helped this community. And I got there's got to be a lot of great satisfaction in keeping people alive and making sure people are still healthy. So first of all, thank you. And why don't you tell me a little bit, starting off, tell me a little bit about your role as Chief Executive Officer, about the hospital. Then we'll get into what the hospital does and some of the services.
Sure. Appreciate being here, as I said. And I would tell you, first of all, Harrington is 87 years old, 1931, great institution, really focused as a nonprofit community hospital, providing great care for this community. And what I would tell you is in my 11 years there, we've focused on growing the services and trying to help people in the community get care locally. It's really all about not having to travel, especially with limited travel capability, to not have to travel to Wooster or Boston for care that we could provide locally. To that end, we've added a lot of primary care physicians and many other specialists to allow Harrington to be the place of choice for the community. And as you alluded to and know, Harrington is the largest employer in the region. And we take a lot of pride in that because that's a lot of local jobs. And for us, it's a very meaningful way to give back to the community as well and be part of this important community aspect. We are, every day though, I will assure you that there's a lot of challenges in healthcare. It's very complex, but we thrive in that. That's what our mission is to provide healthcare here in the local areas. And as we've grown, we haven't gone away from our mission in Southbridge, that's for sure. One of the events, as you attended the other day, which is critically important, is the renovation of our new ER. Our ER was last done in 1998. And although it's only 23 years or 20-something years, it's really needing an overhaul. Plus, not just a refresh, but adding some new services and new spaces. So we have a brand new CAT scan that will be dedicated just for the ER to avoid any possible delays in getting patients treated effectively right away. We also added, because of the volume growth in the ER, 3 new exam rooms in that renovation, as well as a new front entrance with an overhang, like we did in Webster a few years ago, but with an overhang and a new waiting area and new security improvements, because we really want to assure the utmost of safety and security for all our patients.
You know, Ed, I think a number stuck out for me, and maybe I'm wrong, but I think it's 35,000 people annually. How many patients do they see at an emergency room on an annual basis?
It used to be about a decade ago about 22,000. It's now 28,000 in this ER, and another 16,000 in the Webster ER. And they work hand in hand between both sites.
You know, it's great, and I got to tell you this, you know, and like any other business, customer service is critical, and I've been in your hospital for blood tests and different things. And I got to tell you, the customer service is terrific. Tell me about your staff.
Yeah.
Your doctors, your nurses, and all the other team. There's a lot of people.
Absolutely.
Not doctors and nurses don't get enough credit, but it's a whole team atmosphere.
It's a team effort, and what we believe is being smaller rather than like the larger folks in Worcester, we have an advantage if we use it properly. Yeah. And that advantage is all about the culture and the customer service. And everywhere from my office in responding to anything that comes up all the way down to the housekeeper, it's all about, you know, the front desk when you walk in, someone who smiles and greets you, which I've gotten many compliments about those individuals down there, and making the access as convenient and as easy as possible. So you referenced lab work. We found that that's probably the most highest volume thing people come to our hospital for. So as a suggestion, literally from an employee, we created 2 or 3 spaces to park right in front so you could walk in and walk out very quickly. And that was just really being sensitive to what the community and customer service needs are. We really have a philosophy, how do we get to yes really quick? How do we help the patient or the family member or anyone who needs our services? Because quite honestly, you're not always going to the hospital because you want to, but you need to. Yep. And it's not always a fun environment when you're going through medical procedures. And it's
scary.
It's stressful, and it's scary. And for me, we're comfortable in our roles there, but we got to make sure we make the patient and the family member comfortable in every aspect of what they're going through, because could be a very, very difficult time. We're hearing difficult news or getting treated for cancer in our cancer center. So we're all about trying to make it as good an experience as possible.
Let's talk about a little bit about the cancer center, because I
Sure.
think that's unique to hospitals. There's some, but I mean, for a community hospital, having a cancer center, I think, is a tremendous thing.
Yes.
Tell me a little bit about the cancer center, the people they treat, and how that's working out, because
Sure.
I got to tell you, that's got to be a draw to the hospital.
Yeah.
I'm sure that the next cancer center is quite a distance away.
Yes. So you'd have to go to Wooster if you didn't come to us for both radiation and chemotherapy and other adjunctive services. And we built that as a joint venture with a company on the radiation side back in 2009. When we opened it, we added our own chemotherapy suite with 10 infusion chairs and our own chemotherapy medical oncologist. We now have 2 medical oncologists, a nurse, a physician assistant, and a great staff of nurse oncologists who care for you on that side. On the radiation side, which I think is what we've tried to accomplish, which I think has been very successful, is one-stop cancer care. So if you need both, it's all right there. And on the radiation side, I think we're very fortunate because we have the chief of radiation oncology, and this is probably not known by enough people, so I'm glad I have the opportunity to share this. We have the chief of radiation oncology from UMass, Dr. T.J. Fitzgerald, who actually spends 3 days a week in Harrington. So we have the best of all worlds. We have this world-class guy from UMass who's actually been there from the start, and it's almost like his baby, growing the cancer center.
You know, when I first came here, I took a quick tour of that facility, and it's so modern and up to date. I know you think you said 2009,
Right.
but you go in there, it looks like it's brand
Oh,
new,
it's
and
brand-
the technology is all there in
wonderful.
place. It seems to me you guys are really keeping up with the latest technology in that
Yes.
facility, making sure that you have the best
Yes.
equipment possible, as well as the best staff possible,
Right.
to take care of patients.
Yeah, it has the up-to-date linear accelerator. It does all the bells and whistles that you would need even in a tertiary center. And Dr. Fitzgerald is super supportive of our ability to grow that service.
You know, that's great too, because having cancer is difficult enough in your own life than to have to travel long distances to deal with it. So having that service locally
Right.
has got to help, not only in treatment, but in a big part of that, I think, is your own feelings, your own, psyche as to how you deal with that problem. So having it close by where family and friends can go with you, it makes a huge difference, I bet.
Yeah, and we've had testimonials from patients. We've had people who say it's like a family there. They feel like they're going into their own living room because it's so hospitable. The volunteers that serve there are wonderful. So I would say, and I always say this, I say, look, if you need cancer care services, if you get diagnosed, we're all about, sure, get a second opinion if you need to guarantee that that's what you're having to deal with. But if you need the treatment and we provide the same level of treatment as you would get in Worcester or Boston, then get the care locally because it's repetitive visits. And why travel when you can get the same, physician support and technology and even, I think, a more local community feel in our center.
More welcome. Sometimes you go to
Yes.
bigger hospitals, you don't feel
It's more like
that
a number.
home atmosphere. Yeah, you feel like a number. You don't have
Right.
that comfort level.
Right.
Ed, one of the big issues is, as long as I've been involved in hospitals, and I was in the legislature and different things that I ended up dealing with hospitals, is the cost. And we know that that's the big thing. Frankly, the government squeezing hospitals for cost. We all recognize that. And you're not in an extremely wealthy area here. Southbridge is obviously a lower per capita income. You have some wealthier towns, but it's not a rich area by any
Correct.
means. How does that relate to you in terms of funding for your hospital, making sure that you have the healthcare coverage that allows you to provide this service and still, keep
Sure.
the hospital going?
It's a very tough balance, to say the least. You're correct that we serve a higher percentage of Medicaid patients than normal. The good news is, of course, in this state, almost everybody is insured.
Yeah.
The bad news is Medicaid doesn't pay what our costs are.
That's right, they're squeezed.
So we're ending up with more volume at a lower payment than if we had more Blue Cross or more other commercial payers. So with that, it's a balancing act all the time. And yet our mission is to serve everybody, no matter what, whether it's ER or in the physician offices, et cetera. So we meet that mission. But the challenge and what we try to do in balancing it is, how do we prioritize the services we offer with the cost and the reimbursement, and at the same time, especially in areas like where we've invested heavily, as you well know, in behavioral health and dealing with the opioid crisis with recovery services and child psychiatry, et cetera, Those are not profit centers
Right.
by any means.
Right.
But we believe our mission is to do that. So we squeeze where we can, we cut other services if need be, we get lean, we look at every opportunity to really do it better and cheaper. And in the future, quite honestly, I think the key is going to be community hospitals are critically important to the whole healthcare system, and those that can provide it at a lower cost are going to be the most successful.
You know, it goes to the issue of, hospitals being sort of gobbled up by other hospitals
Right.
from larger institutions, and you've managed not to have that happen to your hospital,
Right.
which I think is critical, because I love the small local community
Right.
hospital. I think the services are better. And as they get bigger and bigger, you kind of get lost in the process. So kudos to you guys for keeping the local part of that. But in spite of that, I see you're also growing. I mean, you've been kind of moving out into area towns and opening offices and stuff. Tell us a little bit about your expansion and why you
Sure.
think that's important and how you're trying to fit services to the needs of a particular community.
Right. So 11 years ago when I got here, I'll give you some numbers and facts. We were very Southbridge centric, and we didn't have many physician offices outside the immediate market area. We also were generating about $55 million in revenue. So that is by any means a small community hospital, and you compare it to the rest of the state. And we felt that it was important to create more access and grow. And when you're growing, you become bigger and better and can spread overhead in a variety of ways. So we grew heavily into Charlton. We grew further enhancing our position in Brimfield, for example. A couple of years later, we took over the whole situation in Webster and saved Hubbard Hospital from going bankrupt, and created what I would call a very sizable campus there with a brand new ER ultimately, and other services and more doctors over in Webster, which was really going to go out of business and be way underserved if we didn't step in. And then we furthered our efforts to go into Spencer, which at the time, about 5 years ago now, with a very sizable group there now. We have about four primary care docs, nurse practitioners, 10,000 square feet. And that Spencer site is kind of our reach into north, if you will, northeast, which always was considered a Wooster bedroom community. But if you think about the traffic and the geography, it's easier to get to Charlton or Southbridge if you need other services than it is to Worcester.
Especially going on 290. I've been there.
Absolutely.
It's
Or
horrible.
or Route 9 going into Worcester. So you could just come down 49 and you're here
Yep.
in no time. So we thought that was a really good move, and we really have a great group of physicians up there. And then a couple of more recent expansions, which we felt were critical, was we did urgent care in Charlton, in our main facility in Charlton on Route 20. And then a couple of years later, a year and a half ago probably, we opened up Oxford Urgent Care. There's not any physicians in Oxford. So we kept growing our boundaries. And the most recent, I won't say final growth because I don't think we're ever done,
Right.
is Putnam, Connecticut, where we opened up a behavioral health site with 6,000 square feet for behavioral health services, primarily child and adolescent, as well as recovery services.
Yeah.
And then recently, as you know, we opened up right across the street from the hospital another site for behavioral health, which has been doing fantastic for child and adolescent as well.
It's interesting hearing you go to Connecticut, because I've been in Connecticut for years and years, and I know it's a much more difficult challenge being in a hospital medical
Right.
business in Connecticut than it even is in Massachusetts.
Yes.
A lot more regulated, a lot more squeezing of dollars. The state of Connecticut's having a real difficult time,
They
and
are.
there's a lot of fighting between state government and hospitals
yeah.
in Connecticut. So I guess kudos to you for going into that environment, but that's a tough space to work in.
It is tough. We were fortunate, I think, to be welcomed into the state because the service was so needed.
Yep.
So I think they appreciate us being there. We had to work hard at getting the right contracts so we could get paid for those services, and that wasn't all that easy. It took a little while, but I felt strongly that we already have the infrastructure. Why can't we expand it? It's an imaginary border, if you will, or barrier, and it's literally right over right at the next town over.
Yeah, it's pretty close in terms of distance.
Right.
Ed, I got to give you kudos, because I remember when I first came in hearing that, years ago, Harrington Hospital was struggling financially, and it's completely turned around under your leadership. I heard all kinds of
Thank
good
you.
things about the finances of the hospital now versus what it was. You've done a great job of being innovative, doing the expansion at the same time, making sure that you have financial stability
Right.
and because the bottom line is everything is about money. So you have to have the stability to grow, to expand, and provide quality services. So congratulations
Thank you.
for getting to that point now where you can do that kind of growth. The more you grow, the better it is for people, right?
Right. The growth is important, and in my mind, yes, the finances is important because the mission has to be served because you're financially viable. And you always got to look to the future of what's coming down the pike and what can we make sure we're ahead of to make sure we don't erode that strength, if you will, of a strong balance sheet. And we'll have some years where we're financially doing well and some years where we're struggling. And we need to recalibrate what that means. And what I would also say is, if you do the right thing for the patients, if you do the right thing in terms of service and quality, then the volume comes your way because the reputation gets enhanced and that additional volume that comes with it helps pay for the additional costs that come. You know, people need wage increases every year. There's new technology, there's capital needs. And as we said earlier, the new emergency room, that's a capital cost.
Yep, it's a big investment, and it takes a while to get that return on investment. So you're kind of putting yourself out there, especially in the short term, for what may be a long-term investment in return.
You're
But
betting
it's,
on the future.
Yeah, and
you're committing and investing in the town and in the people and in the doctors and the staff to serve the patients properly.
That's exactly right. You know, I want to get into, I know we got a referendum question I want to talk about, but I want to talk a little bit about the opioid situation with you, because you've been a true partnership, your hospital, with the town of Southbridge in dealing with it. I mean, we get the patients on the street through our ambulance corps, people that overdose, and then we bring them to you, and we get that full coverage treatment. But one of the nice things now is that often after we treat them in the ambulances, they never get to you, or when they get to you, they leave right away. And you've changed that. My understanding is you're giving more services. Explain how you're doing the long-term plan versus the, okay, we treat you for the day, have a nice day, goodbye. Tell me about that.
So first of all, we have a great partnership with the town and with the police in particular as well. We sponsored, if you recall, about almost a year and a half, 2 years ago, the Canine Dog.
Yep.
We helped sponsor that with other community corporations and everything locally. And we've worked closely with the leadership at the police department to really help coordinate the care for these patients, because that's who I think where the interaction interface a lot of the time is. And what I think is really critical on the opioid, because it's really horrible how horrific the issue is, and what we're striving for really is to be on the side of it where the treatment occurs. And getting people into treatment. I always say it's great that people can be, revived with Narcan. But if you revive them and they don't get into treatment, they're going to go through the same cycle over and over until it's, too late. And you have more deaths than you should have. So what we've been trying hard to do is coordinate how do we get them into treatment. And there's all sorts of treatment, all sorts of both medication-assisted treatment and all sorts of access points to enter the system. So if they end up in our ER through the police or through coming in on their own or overdosing by ambulance, it's our job to really assess them and then find a way to get them to hopefully want and cooperate to get into some form of treatment.
Well, Ed, I recall, too, that you sort of have a diversion program, right? So I've been in hospitals literally where people come in on Friday or Saturday night that are drugged up or alcohol, and they're literally laying on stretchers waiting for care because they're not priorities sometimes. So they're sitting in the ambulance or sitting in the emergency room. I know that you guys have been trying to divert some of those drug cases to separate care so they get the treatment they need, and they're really not as expensive as emergency care in the operating room. So tell us a little bit about that.
So first we have our own crisis team that's embedded in the hospital. And that crisis team for psychiatry and for behavioral health and for opioid issues is right there. We don't have to call. A lot of hospitals, they have to call an agency in to respond when a patient arrives. And there's a wait then, and there's not a consistency. Our crisis team, licensed social workers and other folks, are really there to assess that patient, work with the clinicians, work with the doctors, work with the psychiatrists, and determine what's the next best step. Should they be placed in our inpatient units? Should they be placed elsewhere? Are they okay to go? Sometimes we have Section 12s where we have to keep them against their will for their own safety and the safety of the community. But with all that, what we've begun to start with the state grant, which is really exciting, is we have a program where initially, as you say, they'd come in and we'd give them a referral. And 9 times out of 10 or 8 times out of 10, they probably wouldn't follow up. They're in rough shape. They're not going to necessarily be in the best position to follow up with that appointment or even make the appointment. So what we've done is what's called this really warm handoff, is what they're calling it. And in the ER now, our ER doctors are being trained in order to give them the first dose of Suboxone. And when they get that dose, the key is they got to go for the next dose. Well, they're not inpatient, they're outpatient. They leave. Once they leave, it's our job to make sure that they have an appointment the
Follow up.
next day or the day after to get the next dose and to get counseling. And that is all part of the grant to put that in place so it's seamless.
Right. So one of the things that I've been working on is the prevention part. We're trying to keep people from going to the hospital, right?
Right.
So I've been working with the prevention team. We have a town manager, substance abuse council, and frankly, there's members of your staff that are
Right.
part of that, helping us
Right.
to do prevention, particularly with young children and stuff, so they never get involved in the first place, and that's important. But I know that Harrington Recovery Services is part of our team.
Yes.
And they're actually a treatment center on their own,
Oh,
right?
yeah.
And I think they're a separate building from you,
Well,
but they do
there's-
treatment in terms of drug addicts and trying to get them,
Yes.
to come back and get back into normal
Recovery
life.
Services is a large program with probably 20 to 30 clinicians in 4 or 5 different sites. Besides Connecticut, we have Dudley, we have Webster, we have here. So there's multiple places to enter the system. And that's part of our commitment where we've grown both the behavioral health and the recovery services programs because, once again, as I always say, the need is so great. And what we find is that if we don't offer the service locally, it's probably not going to be available to the person locally because they probably won't follow through or be able to get to Wooster or elsewhere.
Right.
So I take that responsibility for Harrington very seriously, that we're the major and many times the only provider of care. So that's how
And
we,
it's not just for Southbridge residents, it's for this whole region.
Right.
So people need to understand that while it's a huge asset for Southbridge, it's also a huge asset for the entire region.
Yeah, we serve over 20 towns, all the way up through, as I said, Spencer, Leicester, all the way to the Brookfields, Brimfield, and then coming back east to Southbridge, Charlton, Sturbridge, but also Oxford and crossing over Webster into Thompson. So that's a swath of about 150,000 lives and a very large geographical square miles. So I think that's important that we have to recognize that large regional approach is what Harrington should be viewed as.
Ed, one of the things that I know from having met with you and talked to you a number of times is your complete respect for the nurses who work in your hospital and your commitment to having appropriate staffing. And I know there's a big issue, it's a referendum question
Right.
out there today that it is really confusing, I bet, to a lot of citizens because they see nurses say vote yes, nurses say vote no. But it's a complicated issue. I happen to know a little bit about it, and I know that it's more difficult than a simple slogan to
Sure.
vote yes or no. So
Right.
let's talk about that referendum question. I know it has to do with mandatory staffing levels. So why don't you
Yes.
tell us a little bit about what the issue is in the first place, and we'll talk about the impact of that on Harrington Hospital.
Sure, perfect question. And I think the key is to educate the public about the issue. Because you're right, the ads that run on TV, especially they're quick and simple, say vote no, vote yes, and it's very easy to get caught up and be uninformed.
Yep.
So I think the key is to educate the community about, and I really appreciate the opportunity to do that because it's a complex issue. And, right now, there's only one other state, we'll start with that, in the country that has mandatory staffing ratios, and it's
California.
California.
Yep.
No surprise.
No, so yeah, they got mandatory everything, right?
Right. So California has these ratios, and they've had them for about 15 years, and the studies that we've seen show that there's no change or no difference in quality outcomes with those ratios as California when you compare it to Massachusetts hospitals, because there's all these quality indicators. The second part of that is that California, and I'll use the MedSurg typical floor as the example. California has, I believe, a 1-to-5 ratio, meaning one nurse for 5 patients, daytime, and I'm not even sure they go at all times, which I'll get to in this referendum. We, in this legislation, would be held to 1-to-4, not 1-to-5. And right now, we staff typically on days and nights, days, evenings, and nights. We staff a little differently each shift based on the patient's needs. But what the referendum would call for is 1-to-4 at all times for 1 RN for 4 patients. And clearly, there are some differences by shift of what the patient needs are. This doesn't address that. So California was 1-to-5, we'd be 1-to-4. The other part of California is there were no financial penalties in the California situation. Whereas here, we'd be subject to, if we didn't meet those ratios, we'd be subject to a $25,000, up to a $25,000 penalty for each incident every day that incident occurred. So that cost would be staggeringly high.
Let's give a perfect example, right?
Well, I'll give you a couple of other pieces to it as examples, because the issue is not just financial, because I don't want it to be all about cost and how the cost drives the care or the quality of the care. It's really a couple of things. One is, if this was put into place, and let's take the typical med-surg unit with 20 patients on it today, I would have to have 5 nurses at 4 patients each to get to 20 patients. Well, I don't always have the luxury of predicting if that patient will be discharged exactly when. So then what happens? If I have a patient in the ER who needs to be admitted, I want to get him up to the floor as soon as possible. And if I have 20 patients and I have the 5 nurses there, I'm meeting the ratio. If I let that patient come up from the ER to the floor, I just went in default of the ratio. I'm in non-compliance, which means I'm subject to penalty.
I mean, wait, you keep the patients down the stairs. I mean, it doesn't
Well,
make
what
any
do
sense.
I do? It makes no sense, but that's what the law would require me to do. And even further, think of the practicality of this. What do I do when I have I'm okay right now, right? I got the 5 nurses, 20 patients. But they say, by the way, at all times. They mean breaks, they mean lunch, they mean 24 hours a day.
You really have to have 6 to take care of 5 or 7 to take care of 5. It's
Exactly.
crazy, yeah.
So that is impractical and not feasible. So that's one big flaw in this statement. And then what happens if a person, let's say one of them called in sick? Do I discharge 4 patients because I don't have a nurse? It's not viable to do that. What we do is we come up with strategies using the nurse manager's judgment as to how to cover those patients. Move people around, be creative. Now, take the ER as the next example, and take your ambulance service in town. So what happens when that ER is full with its ratio? What happens when the ambulance comes to the door? We're going to keep the door closed.
Oh, Jesus,
What's going to happen then? Think of the ripple
You're going to get
effect.
fined if you don't keep the door closed. That's insane.
Well,
It's just
I get
insanity.
fined either way, because here's the dilemma. On the federal level, there's a law called EMTALA. EMTALA was designed to not let hospitals discriminate against what patients they let in the ER. So we take everyone, no doubt. And in the state, there's not even an opportunity to go on diversion anymore for years. So our doors are always open, as you know. And if we can treat the patient and keep them, we do. If we can't, we stabilize them and we send them to UMass usually. So what happens then if my ER is at its ratio? The next patient will cost me $25,000 and I'll be fined and I'm not in compliance. So the nurse manager's going to say, Ed, I can't accept that next patient.
One of the right
What
number of
happens
nurses.
then?
Yeah, you just
And then
think about the liability if something goes wrong too. If you didn't do that, it's
there
just
will
all
be
crazy.
people dying in ambulances is the problem. And the state hopefully will recognize that. Now, then on the backside, let's go further. So we get the patient through the ER, hopefully, we get him onto the floor, and then what? We want to discharge him. Well, there's such a shortage of nurses right now that the state overall, and we probably would need 40 to 50 more nurses ourselves, but the state overall would need 5,000 nurses that don't exist.
Have them, right.
So where might some of them come from?
Connecticut, other states, you're going to try to get them.
And nursing homes.
Oh, yeah, that would be bad. And then
So-
you have nobody there.
Exactly. So they'll have beds, but they'll be empty because they can't staff them, because we will pay more to get them. We'll up the whole thing. Now, the Mass Nurses Association, which is the proponent who put the question in, who is a union, by the way, wants that to vote yes because they want more jobs and maybe an elevation in pay that would come with that.
Right.
We look at it objectively and say, where am I going to discharge that patient if I take them from the nursing home? And what are we going to do on the front end so you don't have an ambulance that you then take out of service because they have a patient in it, you can't go out again? It's a disaster waiting to happen.
Well, that's why you don't want to have government arbitrarily setting standards that are impractical in the real
Exactly.
world. I mean, that's what we're talking about. Voting yes for this sounds good. I think the implication
On-
is somehow you're going to support the nurses, but
More
that's really
nurses-
not.
And here's the thing for municipalities to think about. Let's play this out
Okay.
further. We all like the idea, more nurses is better.
Sounds good, doesn't it?
Sounds great. I love our nurses, as you said before. They do a great job, and we give really great personal care.
Yeah.
And we every day try to look, how can we improve it? What can we do better? But the question really is, there are implications for this. There are consequences, and they're not obvious maybe in the 10-second blip, which is more nurses equals better, safer care.
Right.
Sure, it sounds good. Wouldn't more firefighters be great too?
Of course, if we
Wouldn't
can
more
afford 'em.
police and
Right.
more teachers be better too? You sit in that shoe. Could you
Yeah.
imagine if
Couldn't
they
I-
came
yeah,
to
I
you
mean,
with
it
that
would- if
on a
I-
regulated basis?
You know, if I get more police officers, or let's say I'm required to have more firemen, that means I have to have less police officers to pay for them, or I have
Which-
to have less teachers to pay for them.
which bad
So when
choice do you make?
So listen, there's only a certain pool of money you have. And
Absolutely.
If you divert, let's say, to nurses, and you get more money to nurses, that means you have less money for doctors, for
Right.
secondary staff. So it's going to bend somewhere. The question is
Exactly.
where it's going to bend, and that may mean that the patient
Services-
care isn't as good
Yes.
because you don't have as many doctors or support staff.
Correct.
You really need to have the ability to balance your staffing according to what the
Right.
needs of the patients are.
And that's what we do every day, and that's what we want to continue to do. Now, back to the cost question, because the access issue is huge and will affect the community first off. But then there's the cost. So for the state, and the Health Policy Commission at the state level is doing a study to confirm this. But the Coalition to Protect the Healthcare and Mass Hospital Association say there's about a $1.3 billion cost statewide to implement this. Having said that, we think at Harrington it's about a $6 or $7 million new cost.
Wow, that's huge.
It's huge. And for us, that would require us to cut elsewhere. Cut programs out, cut service. So all the great stuff you talked about in recovery services that
Yeah,
we're
it all
doing,
goes south.
how much can I afford to keep?
Yep.
And that would be such a disservice to this community that it's scary.
You know, that's the problem with these kind of slogans, right? Vote yes, for more nurses, it sounds great, and yet people don't get the real facts of this issue. And, you know, they want to be, we all love nurses. I mean, who doesn't love nurses? I
Right,
love doctors.
right.
But it's not as simple as just
No.
voting yes.
Right.
Because it could really damage the hospital and the services and
Yes.
care to patients, and that's what's
So
really.
we would be in the mode of figuring out in a very short time, because the other impracticality of this law, if
Yeah.
it passes, is they expected it to be implemented by January 1st.
From this year?
19.
Oh, geez, good luck with that.
Well, that's the point. So am I in violation January 2nd if I don't hire enough nurses? How does, or
You're going to
do
have to
I?
import them from out of the country because they're not here.
Well, they won't be trained enough anyway. They won't be licensed. And then on the other hand, how do I then determine what beds I can allow to keep open if on day one I'm not staffed enough?
Yeah.
That creates a bottleneck also.
Yep.
So there's dire consequences to all of this. And I think that's the hard part is we need to get the message out. And I appreciate the question and the opportunity
Yeah.
here, because the more we can get the message out, maybe people would stop and say, okay, I like the idea of more nurses, but let's figure out, let's do this. How about this? Why don't we, by the way, what the public should understand, which is really critical, is you could look on a website today through the Mass Hospital Association and know how well we staff or how well we don't staff on any given nursing unit. It's public information. And I always say, in any case, judge us by the quality of what we provide. And if our results are poor, then you know what? You have every right to walk with your feet and go elsewhere. It's up to, and then we won't be viable because we didn't provide a good enough service. It's all about, in my mind, quality and service and taking care of that patient.
Right, but you know, the sad part about the politics here, right, is that it's hard to get people to understand that voting no means a better quality service, not a worse quality. That's the hard thing.
That's the
because
hard to
they're putting out
understand.
in a referendum, putting out in this way, vote yes for better nurses.
Right.
It's going to be hard to explain, to give all the detail to citizens that voting no actually will improve healthcare services.
That's right.
Or at least keep them the same and not
Well,
deteriorate them, which is what
voting
the other
yes
one could do.
will destroy the quality of the healthcare system we
Yeah.
have in this state, which is one of the best in the country.
Yeah, that's-
With all the major academic medical centers in Boston and Worcester and Springfield. But the problem is, the first who will get hit the hardest are small community hospitals like us. That's the problem.
Well, the $5 or $6 million is a big number for you. It's hard to absorb that. You have
Absolutely.
a multi-billion-dollar hospital, or whatever. They have
Right.
more room to absorb than what you would have to
Right,
absorb.
and now, that won't, and I want to make sure there's no rumors out there beginning that means Harrington's going out of business.
No,
That's
but
not
it's-
the case.
Right.
But it creates stress in the system that Harrington will look different
Yeah.
after this would pass, if it passes.
You know, it's too bad, and I hate these referendum questions. Let's assume that it's approved, right? It's voted on. Does the legislature have any involvement in this? Could the legislature say, well, that really sounded great, but
Yeah.
we're not going to go and implement this? So tell me, is this
So
the end of all if this gets passed?
Let's put it this way. If it gets passed, it's really going to be a potential disaster. And I think that's important to remember because then it becomes a crisis and emergency in many people's opinion, and I think in reality it will.
Yep.
So the first thing as part of the regulation in the language is that the Health Policy Commission is required to write the regulation.
Okay.
So once it passes, it still has to be written into a form of a law with regulations that people abide by. So the question will be, A, how long does it take to write that? You remember the marijuana.
Yeah, it's still going on.
Right. So how long does it take to write it,
Right.
realistically? And they can, I would call it, they could adjust it or tweak it, but they can't change it from the original intent, is my understanding.
Who can't change it?
The Health Policy Commission,
Okay.
when they write the regs. Then it goes, the question would be, can the legislature or the governor intervene in influencing either the timing or the intent or the specifics within it? Now, my hope would be, and and even the governor being here the other day for the groundbreaking, he's very healthcare savvy,
Yep.
very aware and very alert. And I'm not suggesting he's taken a position on this
Yep.
in any way yet, but I think he recognizes, I hope, and would, the severity of what this would cause.
Well,
And it's almost like the tornado. It's an emergency crisis coming.
Well, Ed, the thing here is that, and that's why I hate when you try to simplify important issues in one-word ballot questions, right? Because, listen, I'm not an expert on this, and it's not until I have discussions with you that I
Absolutely.
learn enough to say, whoa, this is not what
Time
I
out,
think it is.
yeah,
Yeah,
right.
this is not what I think it is, and
Right.
that's the fear here is that, and I'm not insulting citizens or anything, but it's just they don't have all the information to
This
make
is
the kind of
very
important
complex.
decision that they need to understand. They need to know the ramifications of voting yes or voting no,
Right.
and how that's going to impact the system.
Correct.
Because as you're saying, there's a real-world impact on the hospital of voting yes or no on this question.
And what as we talked at the very, very beginning, in our ER and everything else, our job is very simple. It's to save people's lives.
Yeah.
It's to do the right thing by the community. And we believe we're doing that very well. We've won many quality awards, leapfrog, they call it, awards, where we've gotten straight A's in many, many years. So the question really is, if somebody adds this burden onto us without any clear improvement in quality, in fact, it goes the other way because of the access issue and the closure of beds or services that would evolve from this, I think the public really needs to appreciate that before they go to November 6th to vote.
I know.
And that's hard because I hope a lot of people watch this because hopefully they'll understand that message. And we're trying to do as many forums as we can, get out in the community. Obviously, we could put up a lot of signs, they could put up a lot of signs, but it's more about education and being informed. So you can make a real conscious decision because this is about life and death.
Right.
That's the scary part.
There are hospitals throughout the state joining into this discussion.
Every
I mean,
hospital-
it's great Harrington's doing this because it's important to your future, but are all the other hospitals doing this because what happens if there's no controversy around the question? It's just
Right.
people go, okay, nobody seems to care, I'll vote
I'll
yes.
just vote yes, yeah.
So is that
There's
occurring throughout
efforts,
the state?
there's efforts throughout the state, at every hospital, there's efforts, and many other organizations have joined in. The American Nurses Association, Organization for Nursing Leaders, a lot of physician groups have joined in. ER docs in particular are worried about this because there's a big ad running now with this ER physician saying, we will not have access to our ER
Right.
this way. So I think there's a big groundswell, everything from social media to TV ads, but I think the key is to take the time to understand the full picture and the consequences.
And that's it, the citizens who are watching this show, we're not trying to tell you what to do. We just want you to understand the ramifications of the vote here. It's
Right.
not as simple as just pulling the lever yes. So we want you to understand the ups and downs of this particular issue. And then I'm going to move on because I don't want people, this is not the only issue we're going
Right.
to talk about, but I did want to get that out there.
No, I appreciate that.
And I think, because I think it's critical. I think this is going to have huge impact on you, and people need to
Absolutely.
understand how it's going to, because in the end, it affects the hospital, but it affects the patient, right?
That's the most
So-
important thing it
Yeah,
affects.
so you're going to have to worry about your own care and that you're
That's
getting
right.
best quality care. So
Yeah.
this is something to really think about
Yeah.
as to how you go forward. I want to talk a little bit about the types of services you
Yeah.
provide. Like, I think we all know if you have a heart attack, you go to the hospital. But tell us the typical kind of services that people might not think of when they go to the hospital that you would provide to somebody.
Yeah.
I know you get the labs, right? Some people
Yeah.
have separate labs, you don't go to the hospital.
So-
but tell us about some of those kind of
Sure.
services you provide.
So first of all, we've looked at all the services we offer, and we want to make sure they're appropriate for a community hospital to offer. So we don't offer open heart surgery.
Right.
It's not something a community hospital would or should do. We don't do neurosurgery, back surgery per se. We do actually do some thoracic surgery. We do lung cancer screenings
Yep.
through a CAT scan. We have 2 MRIs in our system. We'll have 2 CAT scans once the ER is finished, a second CAT scan as well, as I mentioned. And then we get into other services that are really important to stay local, like orthopedic surgery. We have a very excellent 4 orthopedic surgeons with a broad array of capabilities. And I think people do not need to leave the area to get their hip or knee or shoulders done. We just brought on 2 new podiatrists. Those are great opportunities to stay local and get podiatry care, including surgery from podiatry. We talked a lot about the behavioral health, so I won't go back into that, and the cancer care program. But overall, what we've found is how far can we go where it's safe to do it locally versus in a teaching, academic medical center setting. And one of the things I wanted to mention also is as we've enhanced primary care and as we've enhanced the specialist and urgent care, one of the areas that we did recognize, and I want to throw in a plug for this, that we did recognize maybe we had some gaps is, especially in Southbridge, is relating closer and more as best we can to the Hispanic population. And to that end, we've been working closely with Renaissance Medical Group. They're located in the other side, from us at least, off 131, the other side, in opposite the Greek restaurant. I forget the address.
The old American Optical.
The old
American Optical.
United Lens.
United Lens building, I'm sorry.
Right, the old United Lens building. And they've made a big investment, renovated a building significantly, and they have multiple services there that will complement what we do. And the wonderful part of that, I think, in this relationship, they have the ability to really work more closely with the Hispanic community and really help us provide more services in that regard. He's going to have primary care there that's opening in just a few weeks. He's going to have home care services based there.
Almost like an adult daycare, right?
And an adult daycare, and an exercise facility, and ultimately perhaps even a pharmacy, I'm not sure. But I think all those services coordinated well from his end, and it's Jesus Suarez is the president of the company, but his services coordinated from his end, and then relating to getting lab work at our place, getting imaging, getting wound care services. We have a wound care program that we have. And helping with transportation and other needs, I think is a huge benefit for the benefit of keeping people healthier. It's all about, and quite honestly, I met with him recently, and it's all about helping the patient not have to be in the hospital, helping them avoid the ER, so they can get the right care in a less costly, more convenient space.
My understanding too that he's trying to recruit doctors from Puerto Rico, which we could always use for the Latino community. Obviously, they'd be more popular if they can speak the language and communicate. That communication I have found, and I've loved the Latino community in town. They've been very, very good to me, and we've developed a great relationship.
Right.
But one of the things I heard when I came here is that the Latino community was afraid to come to town hall because it really wasn't people here that spoke the language and
as friendly, if you will.
Yeah, so we've doubled that. We had
Right.
2 when I were up to 4 people who spoke Latino. Our police department, we constantly recruit, and about half of our department speaks Spanish. So we're really working hard as a community
Absolutely.
to build in that relationship.
You got to reflect the diversity in
And that's what you're talking about in
town.
the hospital thing is
And
connecting.
he could complement us that way. And I actually attended with him. I participated on a trip to Puerto Rico, and we met with the Minister of Health there, talking about how can we encourage and incentivize physicians, nurses, others down in Puerto Rico, because many are leaving anyway. But why not get them to come here
Right.
and have him engage them so they could be, have privileges at Harrington, but work in his suites and really provide excellent care, but catering to, if you will, that population.
Now, I know I went into the building early when it was constructed. I saw it. It was starting to look nice.
no,
but
it looks great
He's gone
now.
a long way, and I
I
haven't
saw it.
seen it up to date. It's great.
I saw it another week or 2 ago. It looks fantastic.
Yeah, it's not open yet, folks, but it's going to be open soon.
Very soon.
And it's going to be really be a state-of-the-art
Yes.
art place and really driven to the community. So I think that's
Absolutely.
really, really good. But,
Yeah.
I'm kind of eager to see it up and running,
It'll be there soon, I'm sure. Now, the other thing I just want to make sure I didn't forget, when we talked about imaging services, X-rays, CAT scans, MRIs, one of the things the community may not fully appreciate and understand is, for the last 8 or 9 years, or actually over 10, we have a relationship with Beth Israel Deaconess in Boston, radiology group, to be on site as well as through telemedicine, read all of our images. That is a huge difference than you would find in a typical community hospital. It
And
really
elaborate a little
raises
bit
the
on
bar.
telemedicine. Explain, because this is a whole new field, right?
Yes.
A lot of stuff is being done through video cameras
Yes.
and connection. Tell me a little bit, because again, it's one of those things where technology is becoming a huge advantage
Yes.
for doctors to be able to communicate with each other and specialists to be able to look at reports and things. literally, directly
Yeah.
through a communication
So-
device. So talk about that a little
So
bit.
in imaging in particular, diagnostic imaging, radiology, X-ray, we have everything on what's called the PACS system, PACS, and that PACS system takes that image digitally, and then it can push it anywhere in the world, literally, through the web, and still be protected from a HIPAA and compliance standpoint. And that image, for example, if you're an orthopedic surgeon and there's a patient in the ER and they get the image of their hip or knee, he could see that on his phone and determine what to do then. That wasn't happening.
It's an amazing different world, right?
Amazing. So that's one piece from the standpoint of, and we could do it also for cardiology tests that we do digitally and other things. So it's all available in the electronic record and interfaces perfectly well. So, and we could send it to another hospital if the patient's going elsewhere for some care or whatever. The next piece of telemedicine or virtual health, they call it now, will be how can you, from remote locations, have clinicians communicate with one another and with patients. So we might have a patient, and we're starting to look at how we can do it even more. We might have a behavioral health patient, say, in Webster, but our staff is here.
Yep.
What can we do technologically to create that connection so we don't lose a half hour going each way there, or pull the person from here when we can treat them over the internet that way? And that's really going to be the wave because there's such a shortage. How can we make up for it by technology?
I think about, you might have a world-class, doctor in some specialty care that's in Worcester. And you
Consult
can't get him
with
there,
him.
but you can consult with him right live and have that
Absolutely.
direct conversation
Right.
and have him see all the test results and everything. I mean, it's just amazing how fast that can all
Yes.
occur now.
There's
And
a lot
time
more to
means
come.
Times mean lives, right?
Right.
I mean,
A lot more to come on that. Well, we already have an example, 2 examples I'll give you. We have a stroke program. So if a patient comes through in a situation of stroke, we have full electronic digital connectivity with UMass. And they help direct what we should do with that patient because they have that expertise. But we have the patient. And do we treat them with X, Y, and Z until we can get them in an ambulance to go up there if it's appropriate for stroke care or otherwise? We also have, and we've had this since 2009, we have an ICU, but that ICU obviously physically is staffed by our nurses and our doctors. But we wired it back in '09, whereby all the electronic record information, all the medications, all the cardiac monitoring, and all the visual opportunity in the room through cameras and audio is sent up to UMass, where they have what they call a bunker, where they monitor 200 patients with intensivists who work in ICUs typically, and anesthesiologists and others, because we couldn't afford to have that level of people on site 24/7 a day. So our people are the hands-on people, but you're getting the care basically with the hands-on people through the advice and oversight, whereby they even have the ability, if somebody's a little out of whack, they may see it even before us. They'll call us and tell us, go take care of that issue on that patient.
Hey, this is a good reason why people are living longer because we have
Absolutely.
the ability, the quality of healthcare is tremendous, especially in the United States.
Right.
People don't realize how good our healthcare system is compared to other countries and what other people deal with. So we're light years ahead in some areas, and that's why, I hate when people want to play too much with their healthcare, especially when
Right.
government wants to play with it because
Well, and that's it.
they don't have the expertise that the
No.
doctors and the people have in the field, and they keep trying to, they think because they're in the legislature they can all of a sudden craft something that helps everybody. Good intentions, usually bad results.
And we all know that there's a tremendous cost to healthcare, and especially if you're an employee, you pay out of pocket for certain things. And we're self-insured as an employer, a large employer, and we've, I think, done quite well in helping create wellness programs for our employees because then we both save on the cost of healthcare. So what we've been able to do, just the latest is, for the last 3 years, our health insurance costs have only risen about 1.5% per year.
I'm jealous because ours go up 7% or 6%.
Well, you might want to join
sometimes
our team.
11%. So I understand. Oh.
But it's an ability to have that care be rendered in appropriate settings, so people and get the right arrangements on drugs. Drugs is a very high cost piece of healthcare right now, so it's up to us to really help our employees understand and their families what they can do to take better care of themselves as well and be more compliant with things. So that's just another aside as an employer.
Ed, we've been talking quite some time. I'm going to kind of end the show.
Sure.
But I want to give you an opportunity to speak directly to the people of Southbridge, right?
Sure.
So I'm going to give you a couple of minutes to talk directly
Sure.
to them and tell them whatever message you'd like to give them about healthcare, about the hospital.
Sure.
So I want you to shoot and take a few minutes just to kind of talk directly to the citizens.
Happy to. Thank
Look
you.
right into the camera here and we'll
All right. Well, what I'd really like to, which one am I on? There we go. What I'd really like to impart to the community is we're very thrilled to be the largest employer in the area and really be the key provider for healthcare to this entire community like we spoke about before. But it is a privilege. It is a privilege to serve the residents of Southbridge. And, clearly, I think we take that very seriously and we want to continue to provide more and more services rather than reduce services over time. I think what's critically important is that from our standpoint, we think once you're educated, it's important to vote no on this ballot question, number one. We think that's important because our nurses and others have concluded that access would be a huge issue and the quality would not improve, it would get worse quickly. So we really hope that you learn about it and take that message very, very seriously. We'd hate to destroy all the good work that we've done for the residents of this community. And then finally, I'd say, when you're thinking about where you should get your health care, and it's like with any other service or business, we hope that you try if you haven't tried Harrington. And we hope that also we're very open-minded. If you have an experience that was less than a 10, we'd like to really know about it because we want to take that seriously and improve every which way we can. Because we think as a service business, and we're not dealing with widgets, we're dealing with people's lives. We take it very seriously and we want to do everything possible to improve the quality of people's lives. So with that, if you have any questions, don't hesitate to reach out to me. I'm happy to talk to anyone in the community. Thank you very much.
I'd really like to thank Ed for coming on the show. We in the town of Southbridge, especially the town staff, we are extremely pleased to be able to work in a partnership with Harrington Hospital and you, Ed. We know that the hospital has donated to many positive things like our police department, and I appreciate that relationship and looking forward to a long-term relationship.
Well, thank you.
We see you as a hospital and as a healthcare, but we also see you as an economic development kind of asset, right? Because as you say, you're probably our biggest job creator in the town. No question about it, and we appreciate all the people who work at the hospital. I talk to so many of the professionals over there, and I'm impressed every day with the kind of quality and frankly, the personality and the caring of your staff. So thank you for all you do for our community. We appreciate it, and thank you for being on the show.
Hey, my pleasure. Thank you very much.
It's always a pleasure. Always.
Thank you. Great.